Okay, friends, welcome to Dr. Gurmeet Singh, and this is we are very grateful to him to have offered to deliver this talk on HPLC, thalassemia syndromes. Dr. Gurmeet Singh is a graduate from All India Institute of Medical Sciences. He has done DM in hematology, and currently he is a hematologist and hematopathologist at JL Hospital and Research Center in Bhilai. Right now, we have 14 attendees. Okay, you can start.
Okay, sir. So, very good evening to all. So, what we'll be doing today is we'll just have a overview of what thalassemia is and how to diagnose it. Now, the important point, sir, I'm not able to see that screen also. Can you put it on?
You just say next slide and I'll change the slide. Can you?
Sir, I'm not getting that screen.
The screen is not visible.
I'm not able to see the slides. Yes, sir, I'm not able to see the slides.
And that is a problem at your end, but what about others? It should be there. Just a moment.
We're getting the page hematology training.
Okay.
No, now it's there, sir. Yeah, now it's there. Yeah. So next slide, sir.
Yes. There will be some.
So let's all start. Okay, sir. Okay, sir. So as we all know, we all are aware of the basic structure of the normal hemoglobin. That is the alpha chain and the beta chain with the iron sandwich in between. So this alpha chain and beta chain are two alpha-like and beta-like chains, we can say, because at different time of the organogenesis and the development, a different alpha-like chain combined with the beta-like chain and give rise to various hemoglobins, right from the embryonic life to the adult life. These alpha-like genes are all arranged in the short arm of the chromosome 16, and beta-like genes, they are in the short arm of the chromosome 11. So next slide, sir. So as during the early part of our development, or as we know, embryogenesis, we have the various hemoglobins. The alpha-like in this slide, we can see the alpha-like hemoglobins are in the left side. That is the alpha and the zeta, and the epsilon, gamma, delta, and the beta are the other hemoglobins. So at various times, all these hemoglobins combine so that we get a hemoglobins at different times. That is the embryonic hemoglobin, the fetal hemoglobin, and so on. Each hemoglobin has a characteristic time when it is present and when it goes off. That is, it switches on so that that hemoglobin is produced, and it switches off so that the other one replaces it. And this is all based on the oxygen requirement in the body. As we say, the fetal hemoglobin is the one which has more affinity for oxygen. So what it does is it catches oxygen more readily from the maternal blood, but its delivery at the end of the fetus is not that good as compared to the adult hemoglobin. So during the intrauterine life, the whole existence is geared towards getting the oxygen from the maternal blood and delivering it to the fetus. This fetal hemoglobin is important because it's there right at birth, and the percentages are very important. We should keep that in mind because during the development they'll then come down. The first year or so, it will come down to the adult level, that is next less than 2%. Next. And after that, the adult hemoglobin, that is the HPA, the alpha and the beta combination that we generally see, is the predominant one, with a mild contribution from HbA2, the alpha and the delta gene. This alpha and delta gene, the percentage of this A2 is varies between 2 to 3.5%. And the A2 is very important because based on the percentage of this, we we make the diagnosis of various diseases. So next slide, please, sir. Yes, sir. Next slide. Basically, during what we understand from hemoglobinopathies is that it can be a defect in the hemoglobin, whether it could be a structural or we can say a qualitative defect, or it could be a quantitative defect, or there could be a defect in the switching over from the fetal to the adult hemoglobin. So the structural or the qualitative defects are the ones like sickle cell, the HBV, in which there is a change in the whole structure, and the quantitative defects are the ones like thalassemia, in which one of the chains is reduced in productions, like the alpha chain or the beta chain, depending on whether it's an alpha thalassemia or the beta thalassemia. Next slide. We should well be aware of what are the various classification, because the thalassemia, the major, intermediate, and the minor that we talk about, they are generally the ones that is clinically classified. But we, as a pathologist, we should use the term as whether it's a homozygous, whether it's heterozygous, whether it's compound homozygous, or we can say double heterozygous. Next slide. The clinical manifestation is very important because I would suggest that each and while interpreting HPLC or electrophoresis, clinical history should be at hand, because during the course you will learn how important it is to have those clinical history. And the major thalassemia major clinically, it manifests generally by the age of 1 year, it requires repeated transfusion, complications which are less commonly seen in intermediate. It's in between. Sometimes transfusion is required, sometimes not. The patient can lead a normal life up to very long and come only during the exacerbation phase, that is during acute episodes of fever or any other stress factors. Whereas the thalassemia minor type, that they are totally asymptomatic and can go on without even knowing. And the persons which are important to catch, because the minor or the heterozygous form of any of the diseases, whether be it sickle cell or thalassemia, if two of them marry, we can have chances of having a child who is deceased is around 25% for each and every pregnancy. Next slide. So when we go about the approach towards a diagnosis, what we should keep in mind, as I said, is a clinical history. Then we should have a hemogram that all of us routinely do. We should always make a peripheral smear and look at it. And next is the choice of method that we have. We can use either hemoglobin electrophoresis at an alkaline pH, that is most commonly used, and the separation can be then run in a it can be scanned, and various percentages, various softwares are there for each and every company that comes up with this instrument, and we can fairly calculate it with reasonable accuracy. The next is the cation exchange HPLC, that the most of which we'll be talking today, because this is a very simple technique. We get everything in our hand as soon as we have the results, and we can straight away go for keep the diagnosis. Whenever in doubt, we should always go for family study and family history and mutation analysis as and when it is required. Next slide, sir. So today we will be talking briefly, we'll be talking mainly about the cation exchange HPLC. The history, as I said, should be very important, and especially because of the geographical area from which the patient belongs. There are geographical areas which are very types of various hemoglobinopathies. The eastern part of our country has hemoglobin E, which is rampant in the part. In the central India, the tribal belt, the area where I work, it's very the sickle cell disease is very common. And in the northern part of the country, thalassemia is very common. And of course, in a cosmopolitan environment, age of onset, major will have an onset earlier. Frequency of transfusion is important, and the date of last transfusion is most important, because that can affect the result. Suppose a patient is a thalassemia, is a sickle cell homozygous, and if he has repeated, if he or she has got a transfusion just a couple of days ago, and we do an HPLC or an electrophoresis, the amount of HbA will be very high and will interfere with the actual reading, actual condition of that patient. And I have seen many cases in which a false diagnosis of sickle cell trait has been given in place of homozygous, because the last transfusion was not taken into an account. Suppose you get a case in which the recent transfusion history is there, I would suggest that you always go ask for a repeat repeat test after say 3 months, or we can go for a same HPLC of the mother and the father to arrive at a diagnosis. Next slide, sir. Second is a hemogram with the PS. The PS, next slide, sir. The PS gives us a fair idea of what we are dealing with. If there are sickle cell disease, we see this is a classical picture of a thalassemia major child, lots of nucleated RBC, target cells, microcytic hypochromic feature along with polychromasia, and these are the nucleated RBC. Few target cells also seen. Yeah. Then there is lots of polychromasia here. These are polychromatic cells. See, this polychromatic cell, the ones are showed earlier, this is showing the central pallor also. This shows that they have been released from the bone marrow quite early. So this shows that the bone marrow turnover is pretty high, and we can say that it has reached a point at which it cannot increase further, and that is the point from where anemia. Next slide, sir. So a difference here, when we have a look at it, gives us a very fair idea of what we are dealing with. This is just a schematic presentation of the HB electrophoresis, which many of us would be using, and those who are using it would know that, yes, we can get a fair idea about the types of hemoglobin that are present, but quantifying it, sometimes it is difficult if we don't have a real good software and a scanner. The point of application, from the point of application, the hemoglobin which is eluted first is the A2. Along with it, hemoglobin C and hemoglobin E are seen in this region. A little of it is the region for hemoglobin S, along with hemoglobin D and hemoglobin G are the ones which co-elute it. Further ahead is hemoglobin F, then the normal hemoglobin A. All the hemoglobins which travel further than HbA are known as fast moving hemoglobins, and the most common one of them seen in India is example is J mirror. Most of them are alpha variants and they travel very fast. Now the problem with hemoglobin electrophoresis is that it cannot differentiate between A2 the HBC, HBE, and the other group is HBS, HBD, and HBG. Now HB, although they are found in different regions, but then there can be some problems with this. So to differentiate it, once those who are using electrophoresis, what if a band is seen in the region of HBS, they should always do a sickling test. Either it can be using a 2% sodium metavel solution, put a drop of blood in it, put a cover slip, seal it from all the sides, and keep it overnight in a moist chamber and look at it the next day morning. You'll see a lots of sickle cell if it's heterozygous S or homozygous S. D will not show it. So that way we can say that this is HBS and not HBD. Now the British Society of Hematology, they have advocated that before giving a diagnosis of any of the thalassemias or sickle cell or any of the hemoglobinopathies, we should have at least two methods of one for identity, next for confirmation. So we should keep it in mind that whenever we are giving a diagnosis, we should be pretty sure before giving a final diagnosis. In this slide, I have just shown the normal and the two heterozygous and the homozygous beta. The normal will have HbA and HbA2. Heterozygous beta, HbA2 will be a bit more thicker band, and homozygous will have HbF along with A2, and there would be more HbA or the normal hemoglobin. Next slide. Now coming to the main topic of today, that is the HPLC. That is high pressure liquid chromatography. We could also say high performance liquid chromatography because it gives good result. And I jokingly call this highly paying liquid chromatography because it gives you very, very satisfying results. The most common method that we use world that is being used is the cation exchange hemoglobin HPLC. Next slide. It is based on the principle that various charges of various hemoglobins are separated at various pH. Now, and that once they are eluted with the various at various pH, they are read at 415 nanometer. So next slide, sir. This is basically a machine in which we do the variant machine, the Biorad variant machine, which is most commonly used. Now they have phased it out and variant 2 machine has come. It's a bit different from it, but the results are almost the same. And the principle behind it is that they have two different fluids. They have these two fluids, the fluid 1 and the fluid 2, which have different ionic strength. Next slide. When during the process, these two fluids are passed using the two pumps, that is the pump A and the pump B, and are mixed in the part which is shown as mixture. And through this mixture, this is all very nicely controlled by a computer software, and it is then pushed through this cartridge. There is a cartridge inside it, and based on the pH, the hemoglobin which has the least affinity for the cartridge will come out first, and that is hemoglobin F in this case, which is followed by various hemoglobin A, hemoglobin A2, then hemoglobin S, D, and C. Now, once they have eluted from this cartridge, they are then passed through this photodetector cell. Now, the color of the pH changes based on the amount of the color of this fluid changes based on the amount of the hemoglobin that is present in the fluid, and that is detected by this photocell detector and represented to us using a graph. Next slide, sir. This graph is the one which is very important for us to interpret and is known as the chromatogram. So next, sir. So there are various peaks in this graph. Next slide, sir. And there are various peaks in this graph, and these are the peaks which gives a presumptive diagnosis of what it is. Next slide, sir. And these peaks, the they are at various times, and the time at which there is a maximum amount of hemoglobin is known as the retention time. This retention time is very, very important because the retention time tells us, gives us an idea about type of hemoglobin that is present, and that is the identity of that particular hemoglobin. Each and every hemoglobin has a different retention time. Now the amount, once we have identified the hemoglobin, amount of the hemoglobin present is calculated by the area under the curve. That is the area that's shown in the greenish shade. So the area under the one in the greenish shade is divided by all the three areas and gives us the percentage of hemoglobin that is present. So what we get in this chromatogram is the relative percent of hemoglobin present out of the whole. So say out of 100%, we can see roughly there are three hemoglobins. So one would be 40, 40, 20, or so on, as it is shown in the, as it is given chromatogram that we see. Next. Next. This is a classical normal hemoglobin the HPLC chromatogram that we get. The retention time along with the percentage and the area are given at the top of it, and in the below there is a chromatograph that we can say, from which we can get the inference and a visual impression of what we are looking at it. Now this HPLC machine, that is the one with the biorad, they have various programs to be run. The one which is most frequently used is known as the beta thalassemia program, and that is the one from of which all the graphs that you see in the references, in the books that you see, all from the beta thal short program. So they have a particular retention time based on that program only. If we change the program, the retention time changes. So what is beta thalassemia short? Designed at diagnosis of beta thalassemia. So they give extra importance to A2 levels and the F levels, which are shown separately here. Now this is a printout which comes directly from the machine. We can have a computer attached to it along with the software, and we can take it in and print out in whatever format we like. So what we see here is a normal distribution, in which the y-axis shows the absorbance and the x-axis shows the time. So at just after 1 minute, there is a peak which shows an absorbance of around 5%, and that is HbF peak, the first to be seen. Followed by that, there is an HbA peak. Followed by that, there is HbA2 peak. And based on the area under the curve, various percentages are given. This is an absolutely normal chromatogram. A2 is 88%, HbA is 88%, A2 is 2.6% with F of 1%. Normal adult person. Next slide. But there is a whole list of it. I would suggest that all of us should read a book by Barbara Bain, that is hemoglobinopathy diagnosis, in which we can get various chromatograms and detailed description of it. This is a list in which the retention time, the window in which the various hemoglobins, a group of hemoglobins are seen, and we have to differentiate them when we see the further graphs and tell you about it. Next, sir. What we have to remember is the various percentages, the percentage of various hemoglobins that are seen in the normal chromatogram. The first one that we get is F. The second, the P2 and the P3 peaks. The P2 peak is the one in which the glycated form of Hb is seen, and it is raised in the most of the cases. In the case of diabetes, you have high HbA1c. So if someone has a high percentage of P2, we can safely say that he is having high HbA1c and should be investigated further. Although this machine is not made to give a comment on HbA1c. A1C. P3 peak is important because HBJ mirror, which is seen in some part of India or sometimes seen in this region. Then there is an A2 window, there is A0 window, D window, S window, and various percentages of it. Next. Now we'll go through some of the cases so that we can understand things better. So this is a hemoglobin, this is a chromatogram which shows high HbF, which shows HbA very low, and HbA2 of 2.4. So I think all of you should have guessed what it is. This is of a 1-year-old child, if I say, showing high HbF, needing repeated transfusions, HbA 6.7, A2 2.4. So it is the next slide. It's a classical case of homozygous beta thalassemia. So whenever there is an F value which is high, there are certain things that should come to our mind. If an F value is less than 5%, it could be normal if up to 2%. In pregnancy, we can see an HbF value of up to 5%, which is normal, no need to worry. It can be raised in some cases of MDS and aplastic anemia. And if HbF is between 5 to 15%, we can have beta thalassemia trait, extreme cases, not generally seen, or some other HBV. If it is between 15 to 45%, most of the time it could be heterozygous, hereditary persistent of fetal hemoglobin. It could be a neonatal sample, or it could be a beta homozygous thalassemia which has received some transfusion. If HbF is more than 90%, the condition that should come to our mind if a patient is asymptomatic, it is hereditary persistent of fetal hemoglobin. If a patient is symptomatic, it's beta homozygous thalassemia. So next slide, sir. So coming to the next chromatogram. This is of a classical case of beta thalassemia heterozygous or minor. So thalassemia minor or heterozygous beta thalassemia is characterized by HbA2 levels which are in the range of more than 4% and can be up to 9%. Along with it, we should always look at the hemogram because it will show a microcytic hypochromic picture. The A levels are normal and HbF levels are generally less than 2%. So whenever we have an HbA2 a bit higher than the normal is to 3.5%. So if it is higher than 4%, it is definitely beta thalassemia trait. If it is between 3.5 to, so next lecture, if it is between 3.5 to 3.9%, the possibility is that it could be a beta thalassemia trait or there could be an associated iron deficiency anemia. Now, two things to remember here is that iron deficiency anemia, it can reduce the A2 level, and megaloblastic anemia, it can give false high A2 level. So, in all the cases in which the clinical history, the hemogram, and the HPLC findings are not matching, we should always go for either looking at the reference name, either for the iron studies or for the hemoglobin or vitamin B12. So if A2 is less than 3.5, it is normal, but if it is less than 2, then the features are suggestive of alpha thalassemia. So we have to look at the value of A2 also. If it is less than 2, it is suggestive of alpha thalassemia trait or delta beta thalassemia. Now A2 is something which cannot be differentiated from HbE even at by HPLC. So levels which are high, then there are number of possibilities. It could be HBE syndrome, whether it is trait or whether it is homozygous. It could be HB Lepoor or HB Deira. Next slide. Just a few cases. Next, sir. So I'll give a brief history, then we'll look at the chromatogram, and then we'll look at the diagnosis. So this was a chromatogram from our hospital. Since sickling is very prevalent, so when this lady came, she is a 45-year-old lady, a known diabetic. Her problem was that whenever she used to send an HbA1c, the report that would come was some not being able to quantify it. So she came to us, we did an HPLC, found that the HbS levels are high, that is 85.5%. So it's a straightforward case of sickle cell homozygous. But since she was a 45-year-old lady, totally asymptomatic, so it's very, very unlikely that she could be a homozygous sickle cell. So what we did was, at this time, we repeated our test with the second sample. Next slide, sir. And when we repeated it, what we got was this. We did an SB electrophoresis in which we got the same thick band in the S region, SDG region. Then we went for a sickling test, which was negative, and with the finding that she is totally asymptomatic, showing a band in S region, HPLC showing S 85%, but sickling was negative. So we repeated our HPLC with a fresh sample. Next slide. So here what we got was the same sample now showed a peak in the HBD value. Next slide. So we were very confused. What led us? What was the difference in the same lady showing two different HPLCs with two different findings? The machine which tell us what has been fed to it. Next click, sir. So what it has been fed is that if there is something in the range of so and so retention time, it becomes HBS. If it is between the range of so and so retention time, it becomes HBD. So the retention time shift, even a 0.05 seconds, led to a difference in diagnosis. Now everything could be explained with the HBD. Why she was not having high HbA1c? Because her normal HbA was very, very low, so HbA1c would not be detected. Now whatever glycated form is there is of HBD, so it will have its own different properties and would be difficult to assess. So next slide. What I suggest is that whenever we get a finding, taking a clinical history is very important so that we can correlate it with our finding and given proper interpretation. Next slide. Likewise, in this case, we would have given a wrong diagnosis of HBS if we would not have taken a proper history. So coming to the second case, she was a 27-year female, symptomatic anemia since long, had recurrent jaundice episodes, transfusion, a few. See, I have given a history in this case, but I didn't give you in that case. That was to emphasize the role of history taking in diagnosis of HPLC. So now I am giving you the history part. She is having recurrent episodes of jaundice, anemia, transfusion, flu. One was last 1 month back. She had hepatitis pulmonary. Next slide, sir. So from history, we know that there is some problem with hemoglobin, recurrent transfusions. The hemogram showed a macrocytic hypertrophic blood picture. Next slide, sir. So recurrent transfusion with macrocytic hypertrophic blood picture, that would give us a diagnosis of towards thalassemia. But here what we get is HbA is almost normal, HbA2 is 1.6%. So as I said to you a couple of slides earlier, the HbA2 levels are very, very important here. any HbA2 less than 2% is some problem with it, some abnormality. So here what we have to look next, next click, sir. Apart from this HbA2 being very low, 1.6%, we have a figure of M, 225 peaks at the region which is just between 0 to 1 second, 1 minute. So these are the peaks which has not been labeled by the machine. Next slide. These peaks along with an HbA2 very low is highly suggestive of alpha thalassemia. So what we did was we ran a HB electrophoresis and we see a fast moving hemoglobin which is pointed by the arrow. So alpha thalassemia, which alpha thalassemia will show fast moving hemoglobin, next slide, sir. That is most likely to be either HbH or HB Barnes. So here we have combined two modalities. With the HPLC, which we were not getting a complete picture. So what we did was we combined it with the HB electrophoresis. We have fallen back on the time-tested things that we were doing earlier. This slide shows the various fast-moving hemoglobins, and here we suspected HVH. Next slide. So to confirm it, since we had a brilliant crystal blue stain, we did a brilliant crystal blue, and we found various wall qualities. Next slide, sir. So now summing up all these things, we have a symptomatic anemia, we have a HbA2 of 1.6%, we have a peak which is between 0 to 1 minute, electrine on electrophoresis, we have a fast moving HB with valve form inclusion. So our diagnosis would be it is an HVH. Next slide. So the point of showing this case was, next slide. The point of showing this case was that don't always believe what the next slide the company has to say, because this machine, they don't pick up the peaks between 0 to 1 minute. So we have to look at the whole tracings rather than looking at the percentages that are given along with it. Any abnormal peak which has not been quantified and should use other methods when required. Next, and if we have some special stains, that definitely helps. The next case. Next. This is a 26-year-old male with easy fatigability, jaundice, and hepatosplenomegaly for last 7 to 8 years. They say that it's thalassemia phenotype. So when such things come into our mind, there are very few conditions which present with it. Next slide. Keep it in mind, the first thing that we should ask origin of the patient. If he is from eastern part of the country, then the diagnosis is very, very clear. So the hemogram did show the microcytic hypochromic picture with a hemoglobin of 5.6. Next. So he definitely is having chronic anemia. With a very low HB, so we did a HbHbA. So we got a HbA2, which was very, very high, 60%, along with HbF, which was 30%. So what would be our diagnosis? As I said, we should take a history, and if it is from the eastern part of the country, HbE is something which should be considered. Next slide. But HbE is asymptomatic, whether it's in a heterozygous form or if it's a homozygous form. So here is a list of HbA2s, various HbA2. This is something that everyone should have in their desk if you are interpreting an HPLC. You should learn it by heart. Anything which is less than 2% suspicious of alpha thalassemia, between 4 to 9 beta thalassemia trait, between 10 to 14% it is LEPOR, it is very, very rare in our country, 20 to 40% HBE trait, If it is between 40 to 50%, we should suspect HPD gram. If it is 70 to 90%, we should suspect HPE homozygous. But our HPLC is. So what we should do is like in such cases, we should resort to the family study. Suspecting this to be a case of E beta thalassemia. So what we did here was a hemogram of both the parents. The father was normal, the mother showed microcytic hypertrophic indices with a bit higher RBC count, although not more than 5 million that we have thought. But then this is also very, very suggestive that it could be thalassemia trait. Next slide. Then HPLC of both the parents was done, and as it turned out, that father was E trait. As I said, A2 in E trait is generally in the range of 25 to 30%, and A2 in beta thalassemia trait is in the range of between 4 to 9%. So the father here was E2, sorry, HE. The mother was beta thalassemia trait. Next slide. And combining both these two together along with the report that we got of the patient, we can say that. Next slide. Trait, the father is HB trait, mother beta thalassemia trait, so our patient is a compound heterozygous for both HB beta thalassemia. Common words is E beta thalassemia, and they are notorious for their presentation as thalassemia intermediate, requiring on and off transfusions. Next slide. And the interpretation, if an HBE level is in the range of say 67% to 70%, HbA2 level should always have a possibility of HbE beta thalassemia. In all such cases, HbA2 parent should be done. Next slide. Although I know it's difficult, I work in an institute, it's easy for me to get the samples. But if we go about it in a right way, we can always request the clinician and the patient, and they will be more than willing to give the sample to arrive at the diagnosis. Next slide. The next case is of a 25-year-old female. She was detected with heterozygous beta thalassemia on routine checkup during pregnancy. So the next step, logical step, next step, it would be doing an HPLC of the husband. So we did that. Next, and I'll show you the husband was totally asymptomatic, hemogram absolutely normal. Next, but the HPLC findings showed an A2 level which was of the range of around 45%, with a retention time of 3.4. Next, sir. So, referring back to the chart that I showed you, any HbA2 which is in the range of we should always suspect HB being done. Next. So to confirm it, we can do an HB electrophoresis, and since it is a D, next, it will co-elute in the S3G region. I'm sorry for the quality of this slide. The picture is not very good quality. But if we do a proper electrophoresis, there is a good separation, and we can find a band in the region of sickle, SDG region. And so, with the help of these two tests, we can say that yes, this is the inner. Next. There are various references of it. Next slide. Whenever we should resort to a second technique also. Next slide. The one that I showed, sickle, yeah, here it is. as I said, HBE is common in some part of our country, but the levels of 40-45% are generally not seen. So if the percentage does not match with those things that are common in your region or what is known in the literature, we should always look for some other explanation. Next slide. So the message from this message is this case was that there's no single instrument, however sophisticated, that can diagnose the so there are a couple of more cases. I think it will take 10 to 15 minutes more. If Sarah agrees, we can continue with that.
You can continue, no problem.
Okay, sir. See, the purpose is that once you are familiar with this HPLC reading, you can even pick up something which other people have missed. Because recently what I have seen is that the very reputed lab, they have uh, reported this case homozygous sickle. But see, the disease, it does not present with the patient was having microcytic hypochromic blood picture. So a homozygous disease of sickle cell will never ever present with microcytic hypochromic picture. Next slide. So we should always question certain. So in the case, as I had earlier said, we did a family study about radio earlier in some cases. So the family study showed that one of the parents was in fact sickle cell trait, the other was heterozygous sickle cell disease, and the patient so he gave was that of a second beta thalassemia. The next step. Although it next. This is of a young male who had received yearly transfusion for last 6 years, and on examination he had a hepatitis again. Next. So again, we can see that thalassemia intermediate. So we can expect something different from this HPLC. So we see hemoglobin of 4.5, and the picture is of a normocytic normal. Chronic anemia, thalassemia, the picture microcytic hypochromic is what is expected, but we are getting normocytic normochromic. Whether we have a transfusion, previous transfusion involved, or recent transfusion involved, we don't know. Next. But we went ahead with the HPLC because the HB was very low and we didn't have a, we could not wait for an example since. We get here is a from a map which shows HBF, which is very high at 80%, HBA at 16%, and HbA2 at 6%. So we are still in a dilemma whether it's beta thalassemia, with a recent transfusion. It's a backslide from previous slides. See, what we see some abnormality here is see at the arrow. The arrow points at a direction, and we have a slight hump in the upward slope of the HbA2 region. Now this we have not seen in any of the previous chromatographs. This is important here. Next. Here we have a family study. So the father has a monocytic normochromic anemia, the mother has a microcytic hypochromic anemia, and the brother, he has again a microcytic hypochromic anemia. Next slide. Now we'll see the HPLC of all the family members also along with this too. So the father has an HbA2 which is of the level of 9. The mother has an HbA2 of 5.2. So mother is clearly a beta thalassemia trait because 5.2 Hb along with a microcytic hypochromic picture. What about the father? The father had a normocytic normochromic and he has an elevated A2 at the tune of around 9%. Here what we can see is again a hump which is seen just near the peak of the A2. Next slide. This hump again seen in brother, the HPLC of brother of the, and he has a microcytic hypochromic anemia along with next. Here it is. So we see a typical hump A2 at the level of 9. So all next slide, sir. We have three A2s around the region of 9 with a typical hump. So what it could be? So it is generally seen in HB Lepore trait. So HB Lepore is classically defined with a HB 50% as a characteristic hump just near the peak, generally in the ascending leg. The mother is thalassemia, the father is HB Lepore trait, and what we have here is a child who is a double heterozygous for both thalassemia and HB Lepore. Next. And along with the patient, the sibling also has the same features. So both the child are compound heterozygous for HB Lepore and beta thalassemia, and so have a thalassemia intermediate picture. Next. Next slide. This is probably the last case. The 30-year-old primary gravitas. She is went to an antenatal clinic, found to have anemia, and referred for investigation. Next slide. She had a microcytic hypochromic picture on hemogram. Next slide, sir. So what we are suspecting here is something to do with probably beta thalassemia trait. But in HPLC, what we found was A2 was at the normal level of 3%, but there is a long peak, there is a very sharp peak of unknown hemoglobin at 18.2% of total hemoglobin, and it has a retention time of 4.7. So what it is? Next slide. This is very characteristic of Q India. Q India and is found generally in northern part of our country, and this peak is described as a church triangle. It is a very thin, elongated wheel with a total percentage of, next slide, sir, with a total percentage of HBQ to be around 20%. This is an chain variant of thalassemia. And when we do an HB interference, it eludes with the HBS region. Next slide. So for confirmation, interferences which was done, I'm afraid the slide is not. Next slide. Next slide. So this is a hello.
Hello. Yes.
Ah, sir. Sir. So this is a next. This is a study which shows that HBQ is found in India. Q India is not that uncommon, and it presents with an HB of say around 11 grams, 10 to 11 grams. But here what we have is that so we had to we have to look for other causes of anemia as well if the HB levels are not matching to the known given in literature. Next slide. So in this case, serum iron studies were done and serum saturation, percentage saturation and a diagnosis of data Q India along with iron deficiency anemia in the case of primary gravidalis male.
Yes.
Next slide. Next slide.
Okay.
So that will end here. So what I would suggest is that the book that I said, it's a book on hemoglobinopathy diagnosis written by Dr. Barbara Bain, and you can say it's like a Bible for all those who want to interpret HPLC. It's a wonderful book which gives very good correlation and how to interpret the graphs. And so next slide, if in case of any difficulties, I'm always available. Sir is there. You can note down my email ID and I can help you out with any of the graph interpretation whenever you want.
Okay. There are some questions on WhatsApp group.
Sir.
What is the role of Menzer index by Dr. Meenakshi Joshi?
Menzer index is something which helps us in differentiating, in suggesting the diagnosis of thalassemia, beta thalassemia trait when looked in relation to iron deficiency anemia. It is to differentiate between iron deficiency anemia and thalassemia trait in the case of microcytic anemia. See, these index were used in the past very frequently. They are not much commonly used now because we have this better techniques of identifying this hemoglobinopathies. So people don't rely on these indexes anymore and they directly go for either erythropoiesis or HPLC.
Okay. And there is one question by
It is
Dr. Bhargav Kaptan. He says we are using Asani index, Srivastav formula, England Fraser index to suggest possibility of thalassemia.
yes, there are yes, sir. There are around 5 to 6 indexes that are used in diagnosis of various separate iron deficiency from thalassemia trait, and any of them can be used. They have been extensively studied, and there is a lot of literature on it. But most of them, I would say, is of academic interest. Uh, what I've personally seen is that yes, once we look at an the hemogram, if it's microcytic hyperchromic and the RBCs, all of these are related to the MCV and RBC or PCV RBC or MCH RBC. So if the RBC count is high for that degree of anemia, so we have to suspect that it is not because of iron deficiency or any of the deficiencies, and there is something else to it, and we should go for further investigation.
So anyone wants to ask a question, they can raise their hands. You can just press the button on the left side, raise hand. Okay, Dr. Manoj. Yes, Dr. Manoj.
Yes, sir. What is so specific about HBE that leads to so high levels of HbA2?
See, the HbE and HB2, they are both two different hemoglobins. So HbE co-eludes with HbA2. Whenever we give a percentage of high HbE in HPLC, we say it's A2 plus E. So it's very difficult to separate those two. The capillary electrophoresis is a technique in which we can have the separation of both the A2 and E. In HPLC and in electrophoresis, both of these are combined. So able to differentiate which is rage. In all of those cases, most of it is HBE rather than A2, which is rage. But what we
Thank you, sir.
see in that
So anyone else wants to ask a question? Or anyone wants to just add a comment? Hello?
yes,
Okay, if anyone wants to ask a question later on, you can just send it on the mail it on the Google group, and we can continue from there.
yes,
Thank you, Dr. Gurmeet. It was really nice listening to you, and I must, on behalf of the group, I must thank you for taking the initiative.
thanks a lot, sir, for giving me an opportunity. I'm always there for anything related to hematology because that is what I look nowadays. If anybody has any problem in hematology, I'm always there to help them. Thanks a lot.
Uh, I have made a. There was some problem in the sound, but generally it was okay. Majority of the time, I have made a small recording of it, and it will be available in about an hour or so for those who couldn't because of the sound. There was some problem, but uh, then we can listen to it again and again to understand the points. Okay, thank you everyone. We can end here.